work from. Great. Thank you. Okay, so Nicole actually is a physiotherapist who works in the north. And currently she's the regional clinical quality lead in the Northeast Specialized Geriatric Center. And she's done a lot of work at the RCA with the Frail Older Adults framework and helping everyone to understand restorative potential. I think Nicole has done a lot for her organization and the province, really, in terms of helping us to understand and care for older adults a bit better. This is my quick summary of your bio, Nicole. Hopefully that's okay.
Yeah, no, that's perfect. Thanks so much. So as just mentioned, my background is physio. I worked in acute care for probably 12 to 13 years, primarily on medicine and stroke rehab, in acute care, stroke rehab. And then I took a role within specialized geriatric services, again in acute care. So acute care is sort of my baby, my home, definitely recognizing, what that does for older adults. And I'm here today to talk a little bit about functional decline and restorative potential because it has become what I always say is my life's work or my life's mission. I, reflect back as to where I was as a clinician over 20 years ago, and have back then probably did quite a disservice to my patients in terms of thinking about restorative potential, thinking about the opportunities. And so now, over the course of the last 7 years, I've been working with the Regional Geriatric Program of the Northeast, really pushing this idea of functional decline and really focusing on older adult care. And what does that mean in terms of rehabilitation for older adults? So it's become my passion, or always has been, but now I'm speaking about it quite frequently. So I'm very happy to be here today to present a little bit on functional decline and restorative potential. All right, so let's get started. So thank you for everybody who entered sort of their information to the chat. I think we're going to have some director level today. We're going to have some clinicians. This talk really, Trish and I were kind of having a conversation right before about, what is this talk and who is the audience? And I think it's really for a wide range. It can really hit in terms of thinking about your organization and what we need to do, but also thinking about the patient itself and what does that mean for our patients and what changes do we have to do in considering restorative potential. So I always like to start with Walter, and we're going to talk a little bit about Walter throughout our talk today. And, as a clinician, I think just as humans, we often make assumptions about people, right? We see somebody in the hospital, we see somebody on a stretcher, we see them walking in the mall, and we make assumptions right away. And that can be a good thing or a bad thing. I think as a therapist, I always did observation before walking into a room to sort of have an idea of how my patient was functioning prior to my assessment. So what I'd like to do now is in the chat, I would love for you to put in, or if you know how to do annotate on Zoom, you can try that option as well. If you want to put in, what are your first thoughts on Walter here? 1 or 2 words.
And there's no wrong answers.
That's right.
Go ahead.
Great. So Lori's saying not feeling well. Wondering about his mood. He looks distraught, low mood, overwhelmed. So oftentimes when I show this slide, we often see, people are thinking frail, people are thinking weak. Oftentimes when I have physios in the room, they're saying assistive 1. They're kind of telling me a little bit about his function. I love how today we're kind of talking about his mood and sort of how he's feeling, because that's really, really important piece to consider. So I want you to remember, whether you put it in the chat or not, your thoughts on Walter when you first saw him, because we're going to come back to sort of those assumptions that we make at times about our patients. All right. So functional decline. Functional decline, as a physiotherapist, I used to think, 20 years ago, I used to think, okay, so function is physical function. It's the way we walk. It's the way we move. And over time, with my OT colleagues, we definitely started to broaden that approach in terms of ADLs and IADLs. However, now working in specialized geriatrics, I'd say that I broaden it even more. And we have to think about functional decline as a geriatric syndrome. And it's important to recognize that there are many contributing factors to functional decline that will then impact day-to-day function. And so here we see those wide range of geriatric syndromes that impact function. And I want to go through sort of each one at a high level and kind of talk about what is the impact. So when we think about cognition, we think about, an impairment of memory may interfere with ADLs, IADLs, and this therefore impacts their everyday function, right? So if they aren't able to do those things, if they have short-term memory loss, how does it impact day-to-day activities? Mood. So glad that's why I was like, oh, great, people are talking about mood. That's not often a piece that people bring up. So mood, we think about depression or anxiety even may impact one's ability to engage in day-to-day life, right? Can't get out of bed or do their self-care. Can't really see future or what that function can look like. So mood, super important to consider. And to be honest, as a physio, that was probably and still probably remains one of my biggest weaknesses in terms of really understanding how to incorporate that. Mobility falls, again, as my background physio, this was so in my face, and this was what made sense to me. And we think about falls, we think about functional decline, but here I want to push it one step further and think about fear of falling. And so, for example, actually just last night I was talking to my grandmother, so I'll intertwine my grandmother into these conversations as well. She's now 93, lives alone in a very rural part of Northern Ontario. And, just the other day, so I don't know if you know, the weather up here has been absolute chaos, and we've had, just like Barrie, we've had significant rain and freezing rain. And so she has told me, I can't go out, which, yes, I agree at this point. But overall in the winter, she has decreased her activities, stopped going to bridge, stopped going to church, which is so important to her, because of the risk of falls. We've talked about, ways of getting around that and how can we still support her to do the activities that she loves. But fear of falling is a definite contributor to loss of function. Pain, obviously pain, we think about undermanaged pain contributing to loss of activities. However, I also want you to consider the overmanagement of pain and what overmanagement of pain can do to cognition and impact overall function, and how do we also balance the management of pain in older adults so that we are not allowing our older adults to have a pain crisis, but sort of managing it throughout the day, but balancing that cognition at the same time. I always say medications should be, and I should change the slide, but then I'd probably get in trouble, but medications should be over all of these geriatric syndromes because we know that a change in medications, the side effects that occur, can definitely be associated with multiple changes in these geriatric syndromes. So we know that medications can increase falls. We can, impacts pain. It impacts your cognition, your mood, and also even your appetite. So thinking about what medications are currently in place, how can we optimize those, deprescribing, all of those big important pieces that we often talk about, and how does it impact your patient's function. Depending on who's on the line today, as a clinician, I didn't think that was in my wheelhouse, right? Medications were for nursing, or for the physician. But definitely as a physiotherapist, also having worked with, OTs and speech language pathologists or social workers, we need to consider how medications are playing a part and have that conversation with the frontline nurse, with the physicians. Continence. So continence is a big one for me. And I feel the reason I think it's a big one for me is that we consider continence, maybe I shouldn't say we, maybe that's generalization, but we often think of continence as a normal part of aging. And we can definitely say continence is not a normal part of aging. So how do we actually consider the continence, whether it's urinary or fecal incontinence, and how does that impact their engagement in activities? And my prime example is this past winter, Christmas time, my uncle wanted her to come to Ottawa to visit, which is a 9-hour drive for her. So we had figured out a whole way. We're going to drive up, we're going to go get her halfway, then, we'll be able to bring her. There was just a whole plan in place. And her first concern, and here she is being able to visit her son, who she rarely sees, her grandchildren, her great-grandchildren, one that she has never met. Her major barrier was incontinence of urine. And how am I going to manage incontinence of urine over a full day's travel to be able to, do all these activities? And that was really kind of earth-shattering for me because I thought this is such an impact for you. How can you actually stop yourself from being able to visit your loved ones? So thinking about how that impacts and actually working through how you can support them through it. Nutrition, obviously undernutrition contributes to weakness, falls, sarcopenia. We need to ask the questions how they're managing nutrition. We have many, my patient population, many we call the tea and toasters, right? So they're having tea and toast in the morning, they may be having a light lunch. What does that look like throughout the day, and how are they managing nutrition? And then social supports. I think we can all agree that over COVID, we learned some really important lessons that I think we thought we knew, but really in our face, social supports are a significant contributor to function. And without proper social supports, this confers isolation and in turn limits engagement. So definitely important to consider. So now once we've determined that the patient is either at risk or has had functional decline, we now need to think about, what can be restored? What is reversible here? So here we have a great definition from the Rehab Care Alliance. And if you are not familiar with the Rehab Care Alliance, which I'm hoping everybody is, but I definitely encourage you to visit their website. They have so many great resources, and some great definitions. And this is the one that, I use sort of to balance all of my work. Here we say that restorative potential means that there is reason to believe that the patient's client's condition is likely to undergo functional improvement and benefit from rehab. So that's obviously dependent on your own experience as well as the literature. So great. So we have the definition of restorative potential. But when our patient's in front of us, what does that mean? Well, we need to understand what determinants will help us determine if this is restorative. What are the factors? What are the questions? What are we asking? So here we have obviously premorbid level of function. And for me, I would say baseline function. And baseline function is the biggest piece for me. So if you can walk away with one thing, it's understanding your patient's baseline function. And that seems so basic. Of course we know that. However, I can tell you that I've had the most experienced therapist be so caught up in the level of frailty that's in front of them that we lose track of baseline function. And recently, again, I'm from the Northeast, but I've been, doing a bit of a tour of the Northeast, gone to about 3 different communities recently and sat in on interdisciplinary rounds in acute care. Baseline function is rarely brought up. We actually did an audit recently, and it was brought up 12% of the times over 3 days. So understanding baseline function is an important component to establishing restorative potential. Obviously, medical diagnosis, prognosis, and comorbidities. You need to understand what is reversible or what is non-reversible, right? Is this a palliative state? Oftentimes we think here about neurological conditions, cancer, but you may also think about CHF, COPD, diagnosis such as that may have progressed, that may no longer be reversible, and how does that contribute to their restorative potential? And then finally, the last one. And the last one is so important to me. So the ability to participate in and benefit from rehab care within the context of the patient's client's specific functional goals. And then it goes down at the bottom. Cognitive impairment, depression, and delirium should not be used in isolation to influence the determination of restorative potential. And the reason I say it's so important to me, if you heard me talk before, I often say, 20 years ago, I would have used the terminology, there is no active carryover. I would have used the terminology of this is a patient's new baseline. And now, these are words that just make me cringe because we really need to understand our patients' functional goals, right? So if they have great social support, what does that look like if they have cognitive impairment? You don't need active cognitive carryover in order to rehabilitate. You have muscle memory, and you can learn these tasks with proper support. And I often use this slide and I think, well, that was 20 years ago, and I'm sure this is no longer the case. But I was recently in a community just last week where I heard a physiotherapist say, well, this is a new baseline. And then in another round, well, there's no active care. She didn't say active care. There's no carryover. So how can we refer to rehab? And I thought, okay, this is not 20 years ago. There are still definitely conversations around this piece. And so I will continue to push this message of you really have to understand your patient's goals, what matters most to them, what are the social supports that can support this patient to return to perhaps a new level of functioning, but an independent or at least a functional level to return home. So now we've talked about functional decline, we've talked about restorative potential. What are the questions we need to ask to think about what is reversible or not? And this is where we go to functional inquiry. And this is probably the most common way of asking, of trying to depict the information. But then there's also functional assessment. And obviously functional assessment is where you're actually observing the patient. You're having them do the task to be able to see if they can do it or not. Functional assessment is definitely by far, the gold standard in terms of better than functional inquiry. However, sometimes we just, we do what we can, especially in acute care, thinking about, our patients and what they are not able to do. So when you're assessing a patient's function, a few different things. You first have to, and this is what I love about geriatrics because it's a bit of that investigator, right? So you have to kind of tease out the story. So first you have to identify the change. Then you have to situate the change within the story, right? So it's like, okay, so what has changed, but when did it change, and how did it change, and what caused that change, and really sort of tease that out with the patient and perhaps their care partners. So identify the change, situate the change within the story, and then determine the reason for the change. So is it cognitive? Is it physical? What has made this difference? So we're going to go through some of these instrumental activities of daily living to talk a little bit about some of the questions that I would ask that are my key questions. And I'm by no means the expert. I mean, I haven't practiced now, I hate to say it breaks my heart, in 6 to 7 years, still very close to many clinicians, but I still have my favorite questions. But, I encourage anybody that has a favorite question that you feel has been an absolute game changer to please add it into the chat so we can all learn from each other. So in terms of driving, the geriatrician that I work with, Dr. Clark, asked this many years ago, and I thought, oh, my goodness, that's key. And she always asks the caregivers, the family, would you allow your children to be in the vehicle alone with the patient, with the client? And the reason that I feel like this has even now hit home more so is, again, my grandmother at 90 years old, so very independent. My grandmother's very independent, cognitively very well, and not very frail at 93. But at 90 years old, she decided she was going to be, done driving. Again, she lives in a rural part of Northern Ontario, and transportation in the north to be able to access things is not very easy. Oftentimes, taxis are not accessible. They don't have free driving services. So my uncle was very concerned and was encouraging her to keep her license. I, on the other hand, had seen her driving. She had recently gotten into a car accident, which we had a long discussion about, and I definitely questioned the safety. And so I could see his point of view, right? Independence is very important. She has no other really big social support. So I asked him, would you allow Nico, his grandson, to sit in the car with her? And he had no hesitation and said, no, absolutely not. Okay, so we need to talk about what is the safety on the road then, and what would it mean for Nico if he was in a different car on the same road as her? And so that made the conversation a lot easier. Other things that you were going to ask is about driving at night. Do you find it more difficult to drive? You may do observation around the vehicle, looking for bumps or scratches, and just asking family if they've noticed any changes in terms of driving in familiar areas or changing the way or the time of day that they're driving. In terms of finances, again, you want to kind of understand what they were doing, right? So were they doing online banking before and have now stopped? Why? Were you going to the bank and have now stopped because physically you're having difficulty? So really sort of teasing that out. I also love to ask about debit cards. And I say this to my daughter all the time, because when I go do my debit card, I'm slow compared to her, and I'm not very old. So for her to say, Mom, like this is, so I often ask family members about debit cards, and that's maybe a new task for this older adult. So what does that look like, and how has it created some difficulty for them? So that's usually my go-to question for finances. Medication, we often turn to blister packs, and blister packs are an amazing resource and support. However, they're definitely not the end-all be-all, right? There are definitely still some concerns with blister packs. So I often ask family members, how do they manage their medications? If they're still out of pill bottles, what does that look like? Do you have any concerns? Have you noticed that they're, renewing the prescription too early, or they don't need to renew the prescription when they should be? Asking about blister packs, have you noticed that they've missed a day or they're doing it in the wrong direction? And what about opening the packages? Do they have difficulty? They're not the easiest. I had a patient once actually cut her finger on one of the packaging. So asking about that, if they drop pills, are they able to pick them up? Have family noticed pills on the ground that have not been taken? For cooking meal preparation, I always ask, does the meal taste different? Right? So if they've been doing the same meal forever, they don't use a recipe, but it tastes different. Why is that? What has happened there? Have you noticed any burned pots or had any concerns with forgetting items on the stove? If I think about my own grandmother again, this is a French-Canadian woman who it is her pride and joy to cook for her family. So every time we go over, even at the age of 93, she wants to make a meal. But instead of having a roasted chicken, instead of having, dumplings and all the fixings, it is still a roasted chicken, but it's a pre-made roasted chicken from the grocery store. She may have made potatoes, boxed potatoes. So she still wants to make the meal, but it has changed. And when I kind of tease out why that has changed for her, it's difficult for her to stand for long periods of time because of low back pain. So from a physical perspective, that has stopped. In terms of shopping, shopping can be difficult for older adults. So we ask, have they changed their shopping habits? Are they now going every day because it's too heavy to carry a large load of groceries in? Or are they now going once a week because it's too difficult to get out every day? What does that look like? No matter what, even if they've lost function, I still like to tease out the question about, are they still able to identify what is missing or what they require? Can they make that grocery list? Right? So just having that ability to understand what they need or not need can really sort of tease out that cognitive component to shopping. Laundry, housekeeping, I think it's the hardest thing we all do, right? I have a housekeeper who I adore greatly, comes every 2 weeks. So what does this mean for them? What is difficult? Are they having difficulty going up and down the stairs for laundry? Are they having trouble maintaining their home? Asking family members, is the home different? Was it before spotless and now you're noticing it's a bit difficult? My grandmother will tell me all the time in French, je paresseuse, which means I'm lazy. Because she says I can no longer do the whole apartment in one go. I have to do one room at a time. Still has a lot of pride of being able to do it, so we don't want to take anything away from her. However, recognizing and trying to keep sort of an eye on what she's able and not able to do and how difficult is it for her. And then hobbies, yard work, obviously that's also one of the most difficult tasks. So what does that look like? I think it's also really important here to also differentiate from a cultural perspective, from a male, female perspective. What is their normal tasks, and has that changed? So were they always doing this? Was it, a female patient that you have, and she was always the cook, and she was always the one cleaning, and now is no longer doing that, and her spouse is having to sort of support. In terms of ADL, so similar questions. You're asking your patients around, you're trying to tease out what has changed, and you're trying to tease out the why. So in terms of bathing, I start right from the beginning and go right to the end. So I start asking questions around preparing for the bath, right? What do they need to prepare? Can they sequence those activities properly? Is it a physical ability to get in and out of the tub? And then sequencing in the shower. And this is where, as a PT, this is my OT sort of getting into my head, but this is important for all of us to understand. Can they sequence? And this is where that functional assessment would really tease this out, where I've had some where they, I thought they were doing great, and the OT did a bathing, an ADL assessment and said, wow, they put shampoo on dry hair, or, right, they just the sequencing of the activities was quite off. So really important to kind of understand that. In terms of dressing and grooming, again, has anything changed? Were they wearing button-down shirts and are now not because of fine motor? Were they wearing, a gentleman that used to wear always a t-shirt under his button-up, now can't wear the t-shirt because he's lacking range of motion in those shoulders. So teasing that piece out. In terms of the cognitive questions you may be asking, do they need reminders to change their clothing? When you go and visit, have you noticed that their clothing is now dirty, which is very atypical for them? So trying to tease out those cognitive versus physical questions. Grooming as well, I always love to know what is their normal, right? So if you have a gentleman and he always well shaved and wore his cologne and took a lot of pride in that, or a woman who always had her hair done and lipstick on, and that was really important to her, and that is no longer happening. So why? What has happened? Is it that they don't want to use a straight shaver and you want to go back to an electric? Trying to tease out why there has been a change, and is there any supports that can be put into place to support that increase or improve function. Mobility, again, as a physio, it's the easiest for me, maybe not for everyone, but really starting to think about the mobility aids, what type, why they're doing it, but then thinking about my grandmother and difficulty standing for prolonged periods of time, asking about endurance and weakness and instability, and teasing out that risk of fall is really, really important. Toileting and continence I'm going to kind of put together. So again, I like to start at the beginning, right? So do they require assistance with toileting in terms of just mobility and transfers, getting up and down? But then also in terms of clothing. So do they need help with the fine motor of undoing buttons, undoing belts? Can they stepwise sequence the activity properly? Incontinence or continence, we definitely talk about the control of the bladder. When I have an amazing example of a patient who they had a cognitive impairment, was being seen by specialized geriatrics in September, and everything had been pretty stable. And they said, okay, we'll see you, next year. Everything's going great. Call us if there's a problem. And in January, they got a call that, all of a sudden she had become quite incontinent. And the son, who was managing her care, lived with her, didn't know what to do. So they did a urine. They did blood work. They did, they had some questions. They tried everything. Finally, the geriatrician was in the house and said, she had to go to the bathroom. Let me go with you. I want to see what's happening. And when she got into the bathroom, there was urgency there, and she couldn't undo the belt. Oh my goodness. When they came out, the geriatrician said, I think there might be an issue with the belt. And the son was like, I bought her that for Christmas, right? So that is a new addition that they had never considered. And she wasn't cognitively well enough or able to really describe what was happening. And so I don't know if that completely resolved the issues, but there was definitely some improvement. And then transfers and feeding, I don't have feeding on the slide, but transfers and feeding, super important to consider. Again, thinking about all of those physical limitations as well as cognitive that might be impairing. So we know the functional impairment, we've done that functional inquiry, or if possible, you've had, support from somebody, if somebody on your team to do a functional assessment. Now we have to actually answer the questions. And I really encourage you to think about, this is not for one specific team member to do. It is not for the physician to decide, or the OT, or the PT, or the nurse. It's for the interprofessional team to come together and really consider all of the different components of function and how do we make a plan of care together. So thinking about this tool, I can't take credit for it. Dana Corsi, our regional rehab and ALC lead, is the one who supported the creation of this tool, and it is actually part of the RCA PDLO best practice framework. It's also part of ALC leading practices as a resource. And I have used this tool. It seems so straightforward. I have used this tool in two different ways. I've used it with clinicians to inform, yes, there's restorative potential, but I've also used it with clinicians who felt there was restorative potential, and we walked through if there's been a change, because the frailty, there's such a high degree of frailty, but there hadn't been a change. This had been the same situation for over a year and a half. So the questions are really important, and we're going to walk through some of the questions in the case study. But overall, you're looking at same thing as I just said. So has there been a change in function, yes or no? What has changed? So you're thinking about those IEDLs and ADLs that we just went through, so that functional inquiry. But I'm going to push the group a little step forward, a little further ahead. Think about that slide on the geriatric syndromes and really thinking about how are any of those geriatric syndromes impacting function. So has there been a change in medications or nutrition or mood? And really think about how that might be impacting and what change might need to occur. Now, when did it change? So you're thinking about acute or subacute, so within the last 6 weeks, within the last 3 months, as the highest level of recovery. Chronic, gradual, chronic, I don't want to ever say that there's no opportunity for reversibility, but in this, I usually like to tease out that story. So especially the chronic gradual, what has been happening? How long were their levels of stability? And what are we trying to get back to? And really talking and working with the family and the patient around those different pieces and coming up with some really clear goals. And then the why has it changed? You cannot skip this step. Why has it changed? Is it a recent acute event? Is it a functional decline? And then also thinking about that RCA, sort of the determinants around anything that may not be reversible. Super, super important. I'm not going to go into a lot of this. This is a rehab pathways, and this is where I'm going to again refer you over to the RCA website to think about rehab pathways. But it really kind of goes through what we just talked about. So one, you're determining eligibility of rehab care. So you're thinking about the level of functional decline. You're determining your restorative potential. Then step two is super important. We want patients as much as possible to be going back to community, right? We want them back in their home. We want them going to outpatient rehab if at all possible. But you need to be able to answer a few questions to determine that. So the second box really helps you think about those questions. And again, this is on the RCA website. So does the older adult require 24-hour nursing care? Right? What does the care look like? Can that care be provided in the community? That one I find is a bit easier because it's very concrete. The second one is where you need your whole team. Does the patient require daily interprofessional interventions in order to reach their goals? So one, you have to know their goals, and it has to be the patient's goals, not your own. And two, you have to have your whole team involved. So what does this look like? So if we think about what is the gap in functional decline, is it a large gap, knowing that, depending on your resources, so here where I live, we do have geriatric outpatient rehab. They will be seen maybe once or twice a week. We have, Ontario Health at Home that can support, but again, there's long wait lists, so they may go a month without care. What does that look like if Walter wants to regain complete function, where he was independent perhaps, now he's an assistive one? Will he regain that function with that level of care, or does he need daily interprofessional care in order to reach that goal? So that really requires the whole team to have that discussion. And then the next two boxes really do focus on the trajectory for rehabilitation, but thinking about the goals, is it maintenance, is it activation restoration, is it rehabilitation, and understanding what your current state asset map, what you currently have available in your region to support each one. So this is my favorite part, because now we have to get back to the patient. So Walter's story. So we walked through Walter's story a little bit at the beginning, and you had some sort of assumptions, and I want you to remember what those were because they're important. They're important to either recognize they could be positive or negative, or help you, or create some negative consequences for Walter. So who is Walter? Well, Walter is an 83-year-old man who recently fell at home. He tripped on a carpet while getting up to use the washroom at night. He presented to the ED by ambulance with complaints of right hip pain and difficulty weight bearing. In ED, x-rays were ordered, and it was determined that he had a right hip fracture, and he was scheduled for surgery later that evening. From a social perspective, Walter lives with his wife of 62 years. They live in a raised bungalow, and they have two daughters that live locally, so they're quite lucky that way. From a past medical history perspective, when we're reviewing the chart, we do see that he has, diagnosis of major neurocognitive disorder or dementia, diagnosed 2 years prior. He has a history of hypertension, high cholesterol, osteoporosis. And he does have supports. So at home, he was getting Ontario Health at Home, PSW twice a week for bathing. He was getting community paramedicine. And he also had a pending VSO referral because he was starting to have some personal expressions. Some may know that as like a verbal response with PSWs. Postoperatively, not surprising, there was some escalating verbal responses. Unfortunately, restraints and Haldol were ordered due to Walter attempting to get out of bed. I hope this is not the case in the South, but in the North, this is a very common, especially where I am. Restraints are highly used, unfortunately, and antipsychotics as well. So luckily enough, Walter had geriatrics ordered, consulted, and a CJ was completed 2 days post-op with some really clear recommendations. Day 5 post-op, we started to see some improvement. So he was now a minimal assisted one person with a walker to the washroom, and he was able to follow simple directions. Restraints and Haldol have been discontinued by geriatrics. So now thinking about Walter. You have Walter in front of you. If you're a clinician, he's one of your patients. If you're a manager or director level, you're hearing your staff talk about Walter and trying to make decisions on his care. And then my question is, what do you care providers need to know to really improve Walter's care or influence that plan of care? So I'd love for you in the chat to add in your thoughts on what information do we need for this piece. Thank you, Jose. I see that you added in the RCA link in the chat. So Walter's goals of care, great. Is Walter able to plan a goal? Anything else from anybody else? Previous history of delirium or agitation, baseline function. Thank you, Jessica. That's what I was looking for. But I feel like even you hit it with the goals of care, right? So really thinking about who is Walter? How do we decide a plan? How do we decide his goals? And we don't know who Walter really is prior to this hip fracture. All we know is a Walter who's in front of us, which unfortunately isn't in the best situation. So let's talk about who is Walter. So here we have, I love to use the Barthel Index. That's a tool that we use a lot in the Northeast, hoping that within your organization that you do have a tool for function. But just overall, what does that function look like? So at baseline, Walter was quite independent. He was eating. Yes, we know he had some assistance for showering. He had dressing was set up by his wife. However, he was physically independent, and everything else was independent, including continence. But his current function is quite different. Right now, he is fairly dependent for all. He's incontinent of urine, and he's an assist for all mobility. In terms of IEDLs, so he had a lot of shared duties with shopping. His spouse cooked. That was a lifelong dependency. But he was somewhat independent with finances and still driving. So even though we have a diagnosis of major neurocognitive disorder on the chart, we do not want to make assumptions of what that means in terms of his overall function. Current function, he is now obviously very dependent for all of those IEDLs. Housekeeping, not surprising, his wife was supporting a lot. They do have a housekeeper bi-monthly, and then medications, there was some queuing, but otherwise doing fairly well, even keeping up with some of the yard work. So we've had a significant change. So this is who we know, right? This is the Walter we know in front of us, and we're thinking, okay, there's some frailty there. We have some concerns. But this is who his wife sees. This is who his daughters know. And this is who we need to consider when we're thinking about planning. And I think in the chat, I have to pull it back up, but somebody said, is he able to do his goals? And this is where it's really important to pull in on family, right? What are the goals? What do we want to achieve here? So when I think about goal setting, it's with the patient, but as well as care partners. So now my question is, do we think Walter has restorative potential? Let's walk through the tool together to kind of walk through Walter's change and if we feel like there's restorative potential. So number one, has there been a change? And I know we're running out of time, so I'm not going to have everybody put it into the chat, but I'm happy for you to do that. Has there been a change? So we know that yes, there definitely has been a change, right? So that we just went over the baseline versus current. There definitely has been a change. And in terms of change, what has changed? So we went over the IEDLs and ADLs, but again, I'm going to push the group to think a little further. What about those geriatric syndromes? So I want you to think, I'm going to ask you in a minute, what geriatric syndromes do you think have been impacted? So all three definitely have been changed, but think about which ones. Now, when did this change? So we know Walter, had this fall, unfortunately, and has had a hip fracture. So he's acute. So it's very clear cut to me. This is not always the case, right? So definitely with somebody comes in with a hip fracture, we know there's been a change. When somebody comes in with dementia, UTI, I will not use the term failure to cope because it is not a diagnosis, but unfortunately we see it a lot in the Northeast as something that unfortunately patients are getting admitted with. What has happened to this patient? These patients I find are a little bit more difficult to tease out, especially when we're trying to determine when did it change. And then why has it changed? So we know Walter has had this recent acute event. So now let's think about those geriatric syndromes. And I'd love if in the chat you can put in really quickly the ones that you feel are being impacted. So out of all of these, if you can pick a few that you think are being impacted, are impacting Walter's function.
Don't be shy, everyone.
Perfect. So Judy, mobility, falls, cognition, mobility, fall, mobility, cognition, continence, falls. Perfect, perfect, right? So if we think about all of these are impacted, right? So he's had a delirium, he's had a change in cognition, he's had the mobility and falls that led to the admission, but also now a change in function overall. We know he has pain, he has a hip fracture, we know there's pain that's contributing. We know that medications will have been adjusted to manage that pain. And potentially even the medications that he received on admission, even though we've stopped them, what does that mean for him and his cognitive changes? And then the continence has also changed. I did not highlight mood and nutrition here. Definitely, here in the Northeast, we definitely deal with the delirium first before really truly assessing the mood. But that definitely could be impacted. And then nutrition, we know, in acute care, our patients are not, even if the food is available, it's not the best. And so sometimes that diet changes. And so my last slide, I'm not going to go into much detail here, but I want you to think about those questions that we went through. Really, really, really consider how you manage with your team, discuss that with your team around the goals that your patient has and how they can be managed either in community or within a rehabilitation center. And the last piece I want to leave you with is rehab is not a setting. It is not a location of care. And I don't know if that came out very well in the presentation, but rehab is throughout the continuum. Rehab is in the ED, and I introduced myself as doing rehab in acute care, and I really strongly believe I did rehab in acute care. And so it is not a location of care, and consider what you are providing in terms of rehabilitation, regardless of your location of care. Thank you.
Fantastic, Nicole. Thank you so much. Just a reminder, at the very end of our session today, Ellen will be putting a link in the chat to our evaluation, so please do fill that out. Does anyone have questions for Nicole right now? Before I ask my question. I'll give you this time. Nicole, while everyone's thinking or typing, do you have the tool that you use in the Northeast, that restorative potential assessment tool? Because it looks different than what we have, the RCA. So the RCA has the framework, and that's what we put in the chat. But the tool that you use, the one that you had a picture of on the slide, is that a different tool?
So there should be a link within the RCA website onto the RCA PGLO best practice framework.
Yep.
It is listed so it'll be listed as NESGC baseline function. So there'll be two intro pieces around baseline function and the full assessment. And then the tool and restorative potential is at the end. But I also believe, I'd have to go back now and look through it. But I also believe there's another section of somewhere in the RCA that does have the exact tool. Thank you, Jose. Perfect. She put in the chat. So quick. So Jose works with me on my team, and she's one of our clinical implementation specialists. So thanks, Jose.
Perfect. Thank you so much. I knew it's buried in there somewhere, but I didn't.
And happy to, before people have reached out before for the tool, happy if somebody wants to email me, and I can send them the copy. So we have a few different versions. I love the versions with the geriatric syndromes. Sometimes we've simplified it to the ADLs, IADLs, and then we've separated mobility, even though it is an ADL. So we have different versions. I feel like with a group that has had the education, the geriatric syndromes is so important to include.
Yeah, I think the big piece after hip fracture is it's such an acute event, right? And there's so much rush around sort of getting the fracture fixed and things like that. That baseline function, we're just in acute care, we're making so many assumptions, really, right? It's Jenny has a question.
Thank you so much, Nicole. I love listening to this talk. I always learn something when I listen to this talk. So now I'm reflecting on the many non-operative fractures I have right now on medicine, as well as some of the fractures that we've seen post-hip fracture as well. I had two questions, if you could tell me what your approach to this is. The baseline function is so important. We have patients right now who are off their baseline function post-fracture. They are showing that they have restorative potential, but their goals seem to be different from their family's goals. And I find that this happens very frequently. Could you comment on what your approach to this situation is, also bearing in mind that, we know that the family are part of their circle of care and, it's not necessarily coming from a bad place, but there may be some caregiver burnout on that end as well.
We have seen this a numerous amount of times, right, where the patients have the goal of getting right back to where they want to be, but the care was already a lot before, and caregivers can't maintain that. I always, and this may be so basic, and I don't, I always go back to what matters most to the patient, and to be able to pull on that piece and try to then discuss with the family and the patient around, so this is what matters most, but how can we work together to kind of reach a happy medium? And I always say, I give the example of, we had a patient in rehab once that said, hey, what matters most to him is getting back into his boat. And the whole team kept saying, like, that's not realistic. Family's like, there is no way, there's no way. And then when we teased out, so why do you love being in the boat? It's actually being outdoors. It's actually being on the lake. So then we were able to negotiate, okay, so what if it was sitting on the dock on the wheelchair? Because mobility, there's no way we're getting you back in a boat. Or building a ramp to get onto a pontoon boat. Amazing. So it's really for me about what matters most, why is that important? And then having conversation with family about how can we try to reach some sort of middle ground so that the patient still feels like we're addressing his goals or hit their goals, and that the family is able to manage that function or that support.
I think one that I see like that is, where the family wants the patient to go, be more independent, go. You can do it, mom, which that's great. They're wonderfully supportive in that way. However, the patient's like, oh my God, I'm so tired. I just, I'm good. Don't worry about me, right? Or it can go vice versa, right? Where the family is like, please let her rest. And the patient's like, let me do more, right? So it can be really tricky.
And I feel like we don't ever capture what matters most to the patient. We don't do that very well, right? Oftentimes what I hear is like, what are your patient-centered goals? Their goal is to get home. Okay, everybody's goal is to get home. Why do they want to get home? What is important? What is their value? And so that, for me, anchors the conversation and then provides sort of the therapist as well their own goals about what we're trying to achieve. But again, it has to be realistic. So what matters most, and then how can we, really tease out why that's important and what is that happy medium.
Thanks so much, Nicole.
Any other questions, everybody? Not seeing anything in the chat yet. Okay. Do you want to move along to the case before Nicole has to go? I know she has to go in 15 minutes. Maybe we can do a quick run through of the case and get Nicole's quick first impressions on this one. Kayla, do you have those slides? Or does Jenny have the slides?
I have the slides. Give me 1 minute and I will try and get them up. And